Morning, everybody. Apologies for the technical issues. I'm quite technically challenged. So I've been asked to discuss with you guys today antibiotics with regard to the treatment in respiratory tract infections. And what I wanted to start with was just the whole concept that on a daily basis, all of us are breathing in 11,000 liters of air on a daily basis. And so therefore we must just really be impressed with how well we are able to stay germ-free generally. So when we talk about the respiratory tract, we tend to talk about the upper versus the lower respiratory tract. And this is a term that is often bandied about. And I thought we should maybe just sort that out. So when it's the upper respiratory tract, we're basically talking about mouth, nose, ear, sinus, throat, larynx, and the trachea. Sometimes some definitions switch the trachea into the lower respiratory tract. But for purposes today, I'd rather have the lower respiratory tract as being the bronchi and the lungs. So if we were to have a look at the pathogens that we see when we come to infections of the respiratory tract, this is the basic organisms that we would be seeing. And as you can see here, there's quite a lot of overlap. So whether we're talking about the nose and the sinuses or the alveoli, often the same bugs tend to come up. So a lot of Staph aureus, a lot of Streptococcus pneumoniae on both sides of the upper and the lower respiratory tract when it comes to bacteria. And then here are our friends, the viruses. Again, lots of overlap, but some that are more specific in certain parts of the respiratory tract. So if we have a quick look here, a lot of adeno in the nose and sinuses, which is again coming up in the larynx and the trachea, and again in the alveoli, where something like herpes simplex would be much more common in the throat, where it's not seen routinely in the alveolus. So when it comes to the respiratory tract, the big question we're always asking ourselves is this a virus or is this a bacteria? And why this is important is obviously this is a stewardship talk. It's all about when or when not to give the antibiotic. So the question becomes, how can we differentiate between a viral and a bacterial infection, especially when it comes to the upper respiratory tract? And I think your go-to response should be that viruses are responsible for the majority of the upper respiratory tract infection. So here we're talking about adeno, coronavirus. This is obviously not COVID, but the previous coronaviruses, our big friend, the rhinovirus. We've seen a lot of respiratory syncytial virus in the last couple of months. And basically just a lot of viruses. And if we take into account that in the last 2 years, everybody's been wearing masks and we have very little immunity to the common viruses that we all would usually have seen, let me tell you, everybody is getting very, very bad colds currently. What we must take into account is that bacteria can occur secondary to this viral infection. And this is usually because the first virus that has entered the respiratory tract has now denuded the epithelial protective barriers that prevent bacterial infection. So the bacteria is normally secondary to a viral infection in these patients. So most acute rhinosinusitis, which is what most people are suffering from at the moment, starts as a viral infection. And usually there is resolution within 7 to 10 days, with usual clear improvement after 5 days. And the problem with this is that most people are not patient enough to wait for 7 to 10 days to start feeling better and will have presented to their general practitioner in this time period. So about 0.5 to 2% of all cases of acute respiratory sinusitis become bacterial in adults. And this is a little bit higher in children, with 5 to 13% of viral sinusitis becoming bacterial in children. However, 80% of all GP visits for rhinosinusitis a very sore throat or odonophagia. They have a very high temperature. And again, we're talking in adults here, not in kids, because a very high temperature in kids is very common with viral infections. The patients have lymph nodes larger than 1 centimeter. You may see a pussy exudate on the back of the pharynx. There may be petechiae, or they may be developing a scarlet, what they call a scarlet-informed rash. maybe a bit of abdominal pain or an abrupt onset. And these are the patients you must make sure you don't miss the strep pyogenes and or the strep throat that we talk about. And they have come up with what they call the Centaur criteria, which is listed here for those of you who are not familiar with it. And depending on the score that the patient develops, you then would feel much more comfortable thinking, well, this is probably a strep throat, and let's give the antibiotic. We don't want to miss the strep throat and miss giving the antibiotic in these patients just because of the complications that can occur in these patients. Moving on now to the lower respiratory tract and what we would call an acute bronchitis. And again, one of the most common diagnoses in an outpatient setting, accounting for about 10% of all visits to the GP. And again, this is mostly viral. And unfortunately, signs and symptoms are not easy to differentiate between viruses and bacteria. And 71% of all visits, unfortunately, end up in giving patients antibiotics in these patients again. And we're not saying that a viral infection doesn't make a patient feel very sick. As you can see in these slides, this is your normal bronchus, and here is a bronchitis secondary to a viral infection. There is lots of inflammation present, and this does make the patient feel unwell. But trials have demonstrated very limited benefit from blanket antibiotics in these patients. And therefore, both the American College of Physicians and the CDC has advised against giving antibiotics in patients with acute uncomplicated bronchitis, because the complications of developing bacterial or resistant bacteria far outweighs the benefit of giving bacteria to a virus. So just a quick word on PCT, which I know Sarah has discussed. And there definitely are two camps. You're either pro PCT or not. But I just wanted to give you my take on PCT. So serum PCT increases quite rapidly with invasive bacterial infections. And it's not elevated when a patient has a viral respiratory tract infection, unless there is a superimposed bacterial infection. And as Sarah mentioned, it's a very rapidly responding biomarker, much faster than CRP, because it's responding to the initial IL-6 and tumor necrosis factor that is released on bacterial infections. As you can see in this slide, coming up a little bit earlier than CRP in your particular patient group. But where it is very useful is that rapid decrease that can be seen when your patient is responding to the appropriate antibiotics. And it is a very, very useful guide for shortening courses of antibiotics. So this is just some data that originally came out, and I just wanted to draw your attention to how it can shorten course and improve outcomes, and how you can see how here it shortened or lessened the patients who were given antibiotics. So here is pneumonia and acute bronchitis. 77% of patients were given antibiotics versus 44% in the PCT group. Rhinosinusitis, 97% of patients in the control group versus 25% patients getting antibiotics in the PCT group. And then again, very nicely shortening the course of antibiotics. So these unfortunately are very long courses, but 12 in the control group versus 10 in the PCT group, 7 versus 6, 6 versus 5 in the community-acquired pneumonia group. So again, it has its place. And for that reason, the Cochrane database of systematic reviews has said that they are supportive of the use of PCT to guide initiation and duration of antibiotic treatments in acute low respiratory tract infections, because it decreases mortality, antibiotic consumption, and shortens duration of antibiotic stay. So very similar to what Sarah showed you, you can see when you can use pro PCT to guide your use of antibiotics. And the place that I think this has a part to play is often in GP practices, and it can be used. There are new point of care systems where it could give your casualty officer or GP just that little bit of confidence to say to the patient, listen, here we can show that your PCT is incredibly low. This is very, very unlikely to be a bacterial infection. and we can quite comfortably withhold the antibiotics in this particular patient. So very useful in upper respiratory tract infections and acute bronchitis patients, who we can then comfortably say you don't need an antibiotic. So to move on to the money when it comes to respiratory tract infections in a hospital environment, and here we're talking about pneumonia, often called the forgotten killer or the old man's friend. And you can see here, it's the 4th leading cause of death globally. So in clinical trials and to make the diagnosis, we need 3 things. Basically, you need evidence of infection. And for this, we're talking about raised biomarkers, whether it's a CRP or a PCT or white cell count or a raised temperature, signs or symptoms that can localize your infection to the respiratory tract, and obviously cough, sputum production, dyspnea, and then very importantly, a new infiltrate on the chest x-ray. Now, I think what's important to remember is that community-acquired pneumonia that is severe enough to require hospitalization is associated with excess mortality over subsequent years that is unrelated to that particular community-acquired pneumonia in patients who survive their admission. And this is even true in young patients. So these are serious infections and things that we want to get treated upfront correctly to try and decrease that long-term mortality that we see. So pneumonia classification is basically community-acquired pneumonia, hospital-acquired or nosocomial pneumonia, and then pneumonia in the immune-compromised. I'm not going to spend much time talking about pneumonia in the immune-compromised other than to say that we need to consider unusual organisms. And the reason we break pneumonia down into these 3 different groups is because you want to get your antibiotic empiric choice correct up front as early as possible, so as to not result in increased mortality. But in the immune compromised, we're talking about our HIV patient, your transplant patient, your rheumatological patient who's on DMARD agents. And these are the patients who have increased chances of having tuberculosis, pneumocystis, CMV, aspergillus, especially in your oncological patient, and non-mycobacterium tuberculosis. So I don't want to talk much more about those, but just be aware that you're dealing with different organisms. So in our good old-fashioned community-acquired pneumonia, the organism we're most likely to see is a Streptococcus pneumoniae. And in more recent studies with better PCR testing, we're becoming aware that in some studies, up to 50% of pneumonia cases are secondary to viruses. So something to take into consideration. And then obviously Mycoplasma and even Legionella, though to a certain extent, we do not see a lot of that in our practice. When we talk about microbiological tests, these are the guidelines as per the South African guidelines, and I will mention where the international guidelines do differ a little bit. So basically, even though we are always keen to have appropriate samples sent to the lab so we know which bug to treat, blood cultures and sputum samples should not be performed on patients with community-acquired pneumonia who are being treated as outpatients. And the reason for this is a very low yield test where you don't often get a bug isolated, and mostly that's because often the antibiotics are given before these samples are sent. So we do not recommend that in our patients. In the South African guidelines, it is recommended that both blood cultures and sputum samples or with a tracheal aspirate should be submitted for before antibiotics for patients who have community-acquired pneumonias with curb scores of greater than 2. This is where the South African guidelines and international guidelines do differ slightly. International guidelines do not recommend these samples being sent off unless you are worried that your patient may be at risk for something like an MRSA or a drug-resistant organism. So somebody who's been recently admitted or has exposure to antibiotics in the last 90 days. But the South African guidelines say that you're completely within your rights to send off a sample in a pneumonia, which has a curb score of greater than 65. The South African guidelines do not recommend the use of pneumococcal urine antigen testing, but they say you could consider Legionella urine testing in a severe cap, and that rapid antigen testing for influenza is not recommended. However, during the flu season, one can consider sending nasopharyngeal samples or for the detection of influenza. So please consider that, especially now as the flu season is currently ongoing. For the treatment of CAP, as per the South African guidelines, and this would obviously be very different to where you are practicing, we can use something simple like amoxicillin in the outpatient setting in a young patient. Whereas in a slightly older patient or somebody who's got comorbidities, you'd want to use amoxicillin clavulanic or second generation cephalosporin. Whereas when we get to the inpatient, we would be more likely to consider intravenous amoxicillin clavulanic or even cefuroxime or third generation cephalosporin in those patients who've been admitted. Please be aware that patients with comorbidities or the older patient who you would potentially expect worse outcomes, you would want to start with amoxicillin clavulanic and not something like ampicillin. And again, the length of treatment is 5 to 7 days, and usually 5 days is what we would say. These protracted extended periods of antibiotics that are longer in the previous guidelines, which suggested 10 to 14 days, is currently not recommended. Just quickly, a couple of words on hospital-acquired pneumonia. Approximately 1 in 7 patients entering South African hospitals are at very high risk of developing hospital-acquired infections. And we're talking here lower respiratory tract, UTIs, bloodstream infections, and surgical sites. And unfortunately, it's because of indiscriminate and inappropriate antibiotics that we select out for antibiotic-resistant organisms. And unfortunately, when you're admitted to hospital, these are the bugs you're going to get, or you're at risk of getting. And one needs to follow one's local institutional guidelines because it's very different if you're in a state hospital to a private hospital, even, you know, a couple of kilometers down the road. So please, again, call your friendly microbiologist for help with this. What are we going to see in a hospital-acquired pneumonia? Well, we're going to see lots of Pseudomonas, your ESBL organisms, which I've listed here, and then our MDR or our XDR organisms, especially Abelmani, depending on which institution you're on. We tend to not see a lot of MRSA in the South African environment, but it is something to consider, and obviously Stenotrogna phomonas. So hospital-acquired pneumonia is an acute lower respiratory tract infection as per the definition that a community-acquired pneumonia would have been. So again, signs and symptoms of infection, signs and symptoms of respiratory tract infection, and then a new chest X-ray changes that occur after 48 hours of admission. A ventilator-associated pneumonia would be after 48 hours of ventilation or of intubation. So again, these are in patients who you really should send off your microbiological samples, and these include both blood and sputum or tracheal aspirates if you've got an intubated patient. The guidelines are very specific to the hospital you're in, but our guidelines for these particular patients would be an antibiotic like tazocin at an appropriate dose. If your patient has got no renal failure, we would use 4.5 grams QID after a loading dose of 4.5 grams, or we could use something like KFP at 2 grams BD or TDS. And then some institutions would ask you to consider adding amikacin at the beginning while you're waiting for your cultures. And as I mentioned, depending on where you're practicing, you may, again, knowing what your bugs you have in your environment, you may want to upfront cover for ESBLs, CREs, or MRSAs. The length of treatment for these patients would be about 7 days, and again, call your friendly microbiologist. So in closing, please protect your respiratory microbiome. Before, many years ago, we used to think this was a nice sterile environment, but we know that your respiratory tract is full of lots of good bugs. And the only way to prevent the bad bugs is to keep your good bugs, and please avoid unnecessary antibiotics, unnecessary broad spectrum antibiotics. Please de-escalate, and please shorten your antibiotic courses.